Hello, everyone, and good evening. Good afternoon for those on our side of the pond. We just are very excited to put on this webinar for you this afternoon, and we would like to welcome our speakers. We have a pretty full agenda, and the faculty for today, I'd like to introduce Professor Ben Burton. Ben, if you don't know him, was trained at Cambridge University and Moorfields Eye Hospital and was appointed to set up a age-related macular degeneration service at the James Paget University Hospital in 2007. He's a research and development director for the Trust and has built up a large retina trial unit with the state-of-the-art imaging equipment running between 4 to 12 trials at any one time, and his research projects include home monitoring and early detection of wet AMD and with AI, and also his role in the gut microme in dementia and AMD, and he's the chief investigator for the UK for Lightsite II trial of photobiomodulation in dry AMD, as well as being a PI for many other industry studies for age-related macular degeneration and diabetic retinopathy. So we welcome Ben to the faculty, and we also welcome Clark Tedford. Dr. Tedford is the co-founder of LumiThera and has served as president and CEO since the formation of the company in 2013. During Dr. Tedford's 30 years in the pharmaceutical and medical device industry, he's held scientific and executive management positions at Omeris, Solentex, Gliatech, and Schering-Plough. Clark earned his Ph.D. in pharmacology at the University of Iowa and then completed his post-doctoral work in the Department of Pharmacology at Loyola University Medical School in Chicago. So we welcome you both. We are very pleased to present to you today our latest data, and as well as some updates and some information regarding photobiomodulation that I think you'll find very interesting, at the least exciting at the most, and we thank you for being here for the next hour with us. So without further ado, we will get started, and Clark, we'll let you lead off.
Thank you, Dwayne. And Ben, it's a pleasure to be able to speak again with you today on our progress. The agenda for today is I'm going to spend a very short period of time talking a little bit about the mechanism of actions on photobiomodulation and really the Valeda multiple wavelength PBM approach. We're going to turn it over to Ben, who can talk to the Lightsite II European post-marketing study that he was one of the PIs in a multi-center trial. And then today, following that, we're going to compare that and bring up the new data that we have from the US pivotal trial, the Lightsite III. We've got top-line data. We're still obtaining more information as we go through, but it gives us an opportunity to compare and contrast what we've seen between the two studies, and as we continue to build this out. This is an interactive program, and there is a Q&A box. We would like you, if you have any questions, just to go ahead and submit them throughout the time of the webinars today, and we'll try to finish early so we can have some discussion around the Q&As. So with that, I'm going to get started here. As Dwayne had indicated, I am one of the founders. LumiThera was founded in 2013. We're in the Seattle, Washington area. I'm the lone pharmacologist. We had a couple engineers and 2 eye doctors to form the company. And our goal was really to create a non-invasive treatment for degenerative eye disease using photobiomodulation to hopefully improve visual function, slow or stop progression of these diseases, and hopefully prevent vision loss and blindness. And with that being said, the technology we're using is photobiomodulation. It's also known as low-level light therapy. It's a very exciting medical technology that there's a lot of research in various areas that are continuing to expand its potential and allowing us to understand the core mechanisms. It really is using low levels of light to stimulate cellular function. Really specific targets can be chosen based on the wavelengths, and we typically use visible to near infrared wavelengths. Right now, it's approved or being used in physiotherapy by particularly in the skeletal muscle area, in arthritis to reduce inflammation and pain. In diabetics, some examples of stimulating and closing wounds have made great progress. In sports medicine, athletes are using it if they tweak their knees or ankles to help improve recovery and get them back into top shape. In other areas, in dentists, in oral cancer, to prevent against radiation damage, and in particular, what we're going to talk about today is in retinal disease. And so the mechanisms that we're targeting in photobiomodulation is 3 different wavelengths. 2 of them target an enzyme. In the cartoon on the left shows a depiction of cytochrome C oxidase, which is a mitochondrial target. It has 2 spots that accept light. The 2 wavelengths are 660 or 670 in the far red that really stimulate the iron copper binding site for oxygen, where the reaction takes place in reducing oxygen to water and pumping protons across the intermitochondrial membrane. The other one is 850, which is near infrared, and it's involved in accepting photons at copper A, which helps shuttle electrons in. And so both electrons and oxygen are key substrates for this regeneration or re-stimulation of the proton pump. That gradient leads to the next enzyme, ATP synthase, creating stored energy. And so as we age, particularly high energy neurons or retinal cells, they tend to be susceptible to reductions in mitochondrial function. Ultimately, if the cell cannot make enough energy, it will trigger apoptosis and cell death. The cytochrome C oxidase is a key 4th of the 5 enzymes involved in electron transport and really can regulate and set metabolic activity. So the Valeda Light Delivery System was chosen and created using these 3 different wavelengths. The third one is actually used to reduce VEGF expression and potentially could be used to augment some of the benefits in the wet AMD area. Our focus has been really on the dry form, though, and the product has been CE marked and available in Europe for about 2.5 years. We have been continuing to build to our clinical trial data over the course of the last 3 years. And this just gives you an example. In the last year, we had 3 studies. We're going to talk about the European Lightsite II trial that Ben participated in. But we also had a study in early DME patients with good vision that came out and was presented at ARVO last year. We've done a biomarker study with electroretinogram demonstrating improvements in ERG and retinal ganglion function over the course of treatments. And most importantly, the most recent study is our pivotal Lightsite III trial, which is similar to the 2-year trials with Eylea or Lucentis. It has a 13-month time point. We've now got the top-line data from the 13-month efficacy time point, and we'll share that today with the group here. So with that, I'm going to leave this over to Ben so he can give kind of a background on the previous study, Lightsite II, that was conducted across Europe. And Ben, with that, I'll run the deck and introduce you and let you take off.
Okay, thanks very much, Clark. Thank you for inviting me. So I was the Chief Investigator in the UK for Lightsite II trial. It's a European trial. You can see the centres here. That we had a couple of 3 centres in Germany, a couple in the UK, Italy, France, and Spain. And it was a double-masked, placebo-controlled, sham-controlled trial, multi-centre, looking at photobiomodulation in really intermediate dry AMD. Next slide. So this is the award-winning Valeda system, which is, as it says, user-friendly, won lots of awards and sort of impressive piece of kit. Next slide, please. We'll look at that in a bit. What this does, it's all pre-programmed, so there's just a couple of buttons on it. You have to press to line the patient up, and then the treatments are given blocks of treatment, and so they're very quick treatment episodes of about 5 minutes, and you do that 3 times a week for 3 weeks. Usually you can spread it over a bit longer. So one block of treatment is 9 visits for 5 minutes each. And if you have a go on one of these, you don't need to be dilated. You just sit there, eyes open, eyes closed, eyes open again, and as a machine will tell you what to do. And it's basically kind of like looking into a sort of psychedelic sun. It's a very interesting experience, which you should have a go at if you ever get the chance. Next slide, please. So it's adjustable tabletop, so it's easy to sort of fit in the office, very user friendly, and really pretty straightforward. Next slide. So the Lightsite II design, the inclusion and exclusion, obviously you have to have AMD, so you have to be over 50 by definition. And the vision, although it could be quite poor, and some of the patients had geographic atrophy, not all of them did, some of them just had a few drusen, so intermediate AMD, and some of them had really quite good vision, not very many having very poor vision from that. You couldn't have center involving geographic atrophy, so we're not, this wasn't proposed as a treatment for people who've kind of got count fingers vision and with loss of the fovea and trying to regain sight. That's not expected to happen. So the proposal was to have 96 subjects, 144 eyes. Unfortunately, as you'll all be aware, COVID happened right in the middle of our trial. So we'd got a few patients in, and it caused a certain amount of havoc with some patients wanted to carry on, some patients were too frightened of COVID to come in. And so it did make the whole trial a bit truncated, was a shame. It was randomized 2 to 1, so twice as many people got treatment compared to the sham treatment. And each block of treatment, each block of 9 light treatments was repeated every 4 months rather than every 6 months, which was the Lightsite I trial that came before this with a smaller number of patients. Next slide, please. So here we go, the baseline, the treatment. So we saw the patients a lot for about 3 weeks in a row, 3 times a week, so Monday, Wednesday, Friday usually, for 3 weeks in a row. Then we didn't really see them for about 3 months. Then they came back and had another intensive treatment, seeing them every day, every couple of days for 3 weeks in a row. And so 3 blocks of treatment a year, and then we assess them at 10 months so that the effect of treatment wouldn't have completely worn off, but also just to give it time to work as well. So that was a plan. Next slide. And so the primary endpoint was best corrected visual acuity, but also some interesting secondary endpoints. In fact, probably more interesting to me, the particularly draw attention to the drusen volume and thickness as one of the secondary endpoints, but also the geographic atrophy growth, one of the exploratory ones there, and also obviously looking at safety and adverse events. Next slide, please. So this is just to give you a rough idea of the distribution. So we had quite a few patients at our sites. We've done quite a lot of research, and we're getting a lot of patients, particularly those that were being seen regularly with wet AMD that we knew were reliable attenders. So we were just treating one eye in the study. Last visit was December 2020, and we're currently on the point of submitting the paper for publication coming from this now. Next slide, please. So 8 European centres. In the end, we ended up with 44 patients, 32 photobiomodulation treated eyes, 19 sham eyes, intermediate AMD patients. So some had geographic atrophy, but by no means all. And primary analysis was the vision, but multiple other OCT-based analyses as well. Next slide, please. 100% Caucasian patients. I work in an area where it's predominantly Caucasian, so not too surprising there. More females than males, again, not surprising because women tend to live longer and therefore more likely to end up with AMD, age-related condition. Mean time since diagnosis of AMD is about 3.7 years, so still quite early. Normally with dry AMD, the sort of time to blindness is roughly 10 years, people that go blind, and 74-year-old patients, so pretty typical, I think. Next slide, please. So the visions at baseline were pretty good. And in fact, one of the difficulties of recruiting patients into the study was the vision having to drop to below 6/9.5, even though they had drusen. So vision better than 70 letters is basically driving standard vision, 6/12, if you're not familiar with the TDRS letter scores. So people with good vision, which does also obviously limit the possibility of improvement somewhat if you're starting with good vision. Next slide, please. So this is the modified intention to treat analysis showing that the photobiomodulation patients treated and planned to be treated and treated a bit and then interrupted overall were getting about 2 letters of improvement, but there were people that missed treatments. Next click. And this is this is just looking at the patients that received all the treatments they were planned to receive. So a lower number of patients, unfortunately, but there are 29 patients. But it was statistically significant, the difference between sham and photobiomodulation. The photobiomodulation patients being about 4 letters better versus about half a letter, it looks like, on the sham group. So there was a difference that was statistically significant in the visual acuity at the end of the period for those that we managed to get into treatment. Next slide, please. So this is, there were some patients that did particularly well, and again, this just shows that more patients as a percentage did better, getting more than 5 lines gain compared to those in the sham group. Again, I don't think this was statistically significant, but it's just interesting to see, and again, a sort of signal that maybe something's happening. Next slide, please. And this is the Mars contrast sensitivity, which is another of the things we are looking at. It's slightly difficult to interpret this, the problem being that the photobiomodulation patients that completed treatment had quite good contrast sensitivity to start with, and the sham group slightly worse than the photobiomodulation group. So although the sham group did improve a little bit with time, the photobiomodulation didn't. But it didn't get any worse either. So it probably not really very meaningful either way, that with the low numbers. Next slide. So we'll be aware that with dry AMD, people often start off with drusen and thinning of the choroid capillaris and end up with atrophic patches and missing photoreceptors and retinal pigment epithelium. So one of the things I'm very interested in is whether we can reduce the amount of dry AMD. The other problem that we have with other treatments that have been tried for dry AMD, particularly from Apellis and in the Derby and Oak study, and also in the GATHER1 trial, is that they've all reported much increased rates of development of wet AMD. So although they seem to have some benefit, those injection treatments into the eye in reducing dry AMD, the wet AMD gets worse. So if we have the next slide. So one of the things we were looking at was the rate of conversion to wet AMD. What this shows is that the high risk for conversion, because a lot of these patients had wet AMD in their other eyes, particularly from our centre, you might expect some of them to develop over a year's time wet AMD in their PBM treated eye or sham eye. But in fact, none of the high risk patients having PBM developed wet AMD, which is kind of reassuring because I was certainly worried about that. Next slide. And in fact, the overall conversion, the numbers here are very small, so not statistically significant, but just again, interesting that the photobiomodulation treated eyes had, if anything, slightly less conversion to wet AMD compared to the sham eye or sham treatment eye or the non-study eye if somebody had, no wet or dry AMD in the other eye, or no late AMD in the other eye. Next slide. So this is also very interesting, I think, the central drusen outcome. So drusen deposits, we know that the bigger the deposits, the larger, the more confluent, the soft type, and the more extensive they are, the more chance you are to develop visual loss over time. It doesn't necessarily follow that reducing the volume and drusen load means that you won't get visual loss. I mean, there are collapsing PDs and stuff, but nevertheless, I think if you say to somebody you can have a choice of lots of drusen or less drusen, they'd probably choose less drusen. So it was interesting that the photobiomodulation group, the blue line there, showed no progressive increase in the drusen load, whereas the sham group did gradually increase, as you would expect. So there's an interesting potential for disease-modifying benefit. Again, over 9 months, you're unlikely to, really know for sure. Next slide. There was, again, a signal, not statistically significant, unfortunately, with the small number of patients. So we had a rather limited number of patients that had geographic atrophy of the ones that were treatment, 8 sham and 8 photobiomodulation. But again, the suggestion from the data was that there was a decrease in geographic atrophy in the PBM treated group at 9 months. So, if this really does pan out with further studies and further data, then this really would be a very interesting thing, in my opinion. Next slide, please. So the safety analysis, next slide, pretty safe. Just because the way things are reported, you'll see choroidal neovascularization. There's one case in the sham group, and then further down there's neovascular AMD. There's one case in the PBM group. That was not one of the high risk PBM. It was not the low risk PBM presumably. So no real difference there, but certainly no sort of danger signal coming up in the patients that we've seen there. Next slide, please. And then, yeah, there's a lot of kind of information there, but it's mostly things like hiatus hernia and carpal tunnel syndrome, stuff that we're really not linking in any way, but you just have to report them anyway. So we couldn't find, or I'm not aware of any significant danger signals. It seems to be a pretty safe thing to do, albeit we need more data. Next slide, please. So this is the sort of the take-home message slide, if you like. So sustained visual improvement, the primary endpoint at 9 months was statistically significant. 4-letter visual improvement at 9 months from baseline for patients that had all their treatments. So 3 lots of 9 is 27 photobiomodulation treatments and 30 eyes. So that was statistically significant. The other things that are really interesting, but we just didn't get enough patients to really demonstrate statistical significance, was the geographic atrophy, decreasing 44% below what would be expected. With the PBM, and also the drusen growth, again, just seemed to stop the drusen growth progressing in photobiomodulation compared to sham, which, you know, if that's true and pans out to visual, to sight saving over time will be really interesting. We didn't find any change in the conversion from dry to the wet form, which has been shown in some of the other studies, and certainly something we need to look out for with the longer follow-up safety studies and registry studies that are being run in Europe, but overall no safety concerns from the data we've seen. I think that's me done. Unless anything else, Clark?
Yes.
Oh no, not quite. Sorry, just wanted to show you how easy it is to treat people. So yeah, so we're getting patients to come in, and once we got it up and running, we had them. They would basically arrive in their taxi. They would nip in, they would have the treatment for 5 minutes, the taxi meter would still be running pretty much, and they'd just nip out and get back in the taxi again. So they were really whizzed in and whizzed out. Next slide. And the next slide. So, yep, I think that's it then. Thank you very much. Great.
Thank you very much, Ben. I also want to point out to those on the webinar tonight that at the bottom of your page, there's a button called Q&A, and if you have a question, you can click that and add your question anytime. We will field those questions at the end of all the presentations, so you have an opportunity to think about it, or you can plug one in there and it'll just wait in the queue for the end of the webinar. Thank you, Ben, for your presentation, and I'll pass it on to Clark and get out of the way here.
Thank you, Dwayne. Ben, that was excellent summary of Lightsite II, and to continue on from that thought, unfortunately, obviously we had planned Lightsite II and Lightsite III to be kind of sister studies, one in Europe, one in the US. Lightsite II was initiated prior to Lightsite III and kind of ran right into the teeth of COVID. We did shut that study down for about 11 weeks while patients couldn't get into sites in some of the centers, and we had conferred with all the investigators to do that. When we brought it back up, we were concerned about fall reemergence of COVID, and so we decided just to let the patients come on through the study. And in the meantime, Lightsite III was starting a little bit later in the US. There was probably more of a blend of academic centers in the UK than in the US. So as COVID came into Lightsite III, most of our centers were able to adapt and restrict patient access and minimize the risk for the patients. So we didn't have as huge an impact because of timing in Lightsite III than we did in Lightsite II. But I think both studies are very similar in terms of inclusion criteria. They were very similar. They were both dry intermediate type studies. The centers here in the US are shown. Lightsite III did enroll 100 subjects. 148 eyes qualified, so each eye could qualify individually. If they're randomized into either a PBM or a sham treatment group. The investigators here, you can see Stanford with Diana Doe and Kwan, her husband, Richard Rose in New York Eye and Ear, Eleanor Ladd at Duke, and I would say that the imaging centers work together in Europe. Marion Monk and the Bern Imaging Center was a central reader for all the sites. She coordinated then when we launched the US study with Glenn Jaffe at Duke, and Duke was the imaging center for the US trial. And I think both in Europe and in the US, we were very excited to have these centers all involved with us and continue to reach out to them as we move further in the research and development of this project. So the Lightsite III, similar to Europe, it's a double masked, randomized, sham-controlled, parallel group multi-center study with 10 centers to look at both safety and efficacy of PBM in subjects with intermediate dry AMD. Similar to the European study, we had an active PBM group with the 3 wavelengths or a sham treatment group. And the sham treatment group is really an active control. We reduce the wavelengths 590, the fluence is reduced about 50-fold. 660, we reduce 100-fold. And the near infrared, since nobody can see it, we can turn it off in the sham. However, it is active, and as you saw in Lightsite II, and we've seen in Lightsite I, there is stimulation. The patients can see the activity at the photoreceptors. Those same cells, the photoacceptors, such as cytochrome C oxidase, are getting some signals. So it's not a pure placebo, but it's very difficult to mask light-based studies. And so we had fluences that were bright enough to allow the study to be masked, but hopefully not have an impact on disease progression. The study included BCVA from 2032 to 2100, and as Ben had said, no central involving GA in the central 1 millimeter fovea. The treatments were similar every 4 months as in the Lightsite II study. We did extend this out to 24 months. And so for these patients, they came in every 4 months for 6 rounds of series. After month 13, the patients had exited. The study was locked, and what we're going to present is the top-line data from the primary efficacy month 13 data. We did have a second primary efficacy at 21 months if the 2 groups did not separate, but we saw a nice significance at the month 13 data with a p-value of 0.02. So it allowed us to unmask the study, and we're continuing to look at the data as it's emerging. Primary endpoint was the 13-month comparison between the sham and PBM. The secondary endpoint was the intra change in BCVA within the PBM group. We also included, for the first time, low luminance, central drusen volume and thickness. We've seen reductions in multiple studies. That's involved as a secondary, contrast sensitivity. And we also included some other exploratory endpoints that we'll be able to talk about today as well. The characteristics of the 100 subjects, 148 eyes, 2-to-1 randomized, PBM to sham, predominantly Caucasian, about 68% female. The mean age was around 75 years, similar to the European trial, but it was a little bit later. So the European trial was under 4 years, and here we're a little bit later, around 5 years from diagnosis. And in the US study, we have about 86% of the patients are taking ARID supplements. We did stratify versus ARID supplements, so both groups would receive an equal balance. And in the European trial, it was down around 30% that were on the ARID supplements. Similar to the last study, the baseline BCVA baseline letter score was pretty good, 70 letters in both groups, so around 20/40 starting vision in these patients. So top-line data showed that at month 13, we did see a statistically significant difference between the PBM group and the sham treatment group. p-value of 0.02. We also looked at from baseline to month 13, a very significant improvement in BCVA with about a 5.5 letter gain, p-value of 0.0001. And you can see it was a sustained benefit with the every 4-month interval, with significance at 1 month and pretty much throughout the study design. I will say at month 13, it was significant. We get about a 2 to 3 letter gain. And we've seen this in the past. We'll go through and look at, we do know that some patients can be very sensitive to low levels and that they do track as if they had a treatment benefit. So this is something that, because of the trial design, we do give away with an active control about 1 to 2 letters. When we look at the distribution across the two groups, we see in the PBM group a very nice shift to the right towards improvement in letter score and best corrected visual acuity. And you can see that from the green in the PBM versus the sham, and that also reflects a decrease in the amount of patients that have letter loss. Look at that a little closer. If we look at patients that got at least a 5-letter gain, we see about 55% of the patients get a 5-letter gain. And that mean for that group is about 9 letters compared to about 40% of the sham. If we look at, I think even more impressive with the starting vision, is that we get about a quarter of the patients or more that get at least 10 letters versus about 14% in the sham. So we're clearly seeing a significant number of patients that are getting a BCVA letter improvement. Now, conversely, if you look at letter loss, while the numbers are pretty small, we do see about twice as many patients in the sham that are having some letter loss versus letter gain, and twice as many that have letter loss versus letter loss with PBM. We had one patient that lost 20 letters. This was a patient that did have a cataract that was worsening, and we will do a stratification for those, pre-specified stratification with those patients that had worsening cataract. We hadn't looked at low-level BCVA, and we did look at it at month 1 after the first round of treatment and month 13. There was really no improvement in low-level BCVA, and in discussions with Nora Ladd, who's tracked this in earlier studies, it may not be the best tracking mechanism for early patients or with intermediate dry AMD. Overall, if you take a look at what we saw in the PBM as well as in the sham group and compare it to patients that were in one of the largest or two of the largest studies that followed GA disposition and growth, the Chrome and Spectra studies, you see that within a couple of years, you're going to be at where those patients were, and those patients lose about 5 letters over the course of 48 weeks. So really, I think is indicative that if we start earlier where these patients have viable tissue before we get to GA, either unilateral or bilateral, we have an opportunity to shift the vision to an improvement in letter score versus a loss as we get later on in the progression of the disease. Contrast sensitivity, similar to the last study, Lightsite II, was not significant. Both the Europe and European trials, we used the Mars contrast sensitivity. Patients typically in 65 or over, if they're around 1.42, that's considered normal vision. So these patients had pretty good vision. Now, we did see in other studies using the FACS, which is a little bit more sensitive to early vision, we see improvements in contrast sensitivity, or with patients that have lower contrast sensitivity and electrolyte, we can see benefits. So we'll continue to evaluate this, but I think this is indicative of the early good starting vision in these patients' population. In terms of drusen and volume, we looked at over the course of time, similar to what we did in Lightsite II. We see over the course of time, typically an increase in drusen volume in the sham, where virtually no change in drusen volume was seen from the beginning to the end of the study in the PBM treated groups. Now, in both studies looking at intermediate patient populations, the amount of drusen is smaller versus later stage. And so it didn't turn out to be statistically significant at 13 months, but it was starting to trend in that direction. If you look at the absolute levels, whether it's in millimeter cubed or change from baseline, you can see from baseline to month 13, we are seeing an increase in drusen volume in the sham patients, where virtually no change in the drusen deposition in the patients with PBM. And this is consistent with the Lightsite II, so we may do some meta-analysis with this set of data. We are seeing a very subtle but in negative, a significant correlation, so that while the patients that get PBM do increase in visual acuity, they're really not showing a change in drusen deposition. In contrast, the shams are seeing an increase in drusen volume and limited improvement in vision. And so there is a correlation. It's not a one-to-one. You may not get an impacted drusen on BCVA, but clearly I think if we're making this tissue healthier, removing the hallmark, it can have a influence indirectly on vision improvement. This is geographic atrophy, and again, very small number of patients with non-central GA here. So there isn't much to talk about, except that you can see we start out very low in GA lesion area. We are seeing an increase over GA growth in the second half of the series, and does look like it's trending similar to what we saw with the Lightsite II, and we'll include these into a meta-analysis. But regardless, I think if we're making the tissue healthier, we would anticipate some disease-modifying effects on GA as well as on drusen deposition. Again, this is a GA showing change area change from baseline. The safety for this study, similar to Lightsite II, there are really no significant safety signals when we look at ocular adverse events. It was randomized 2-to-1 to PBM. We had about 3 to 4% conversion in neovascular. If you would compare it to a similar patient population, about 5% in the PBM. In the non-study eye, it's actually, again, was a little bit higher, around 6 to 7% conversion. And these are well within, I think, normal ranges for this stage of disease, below the 10 to 15% that we're seeing in some of the other studies. Other ocular, administrative, sight conditions, general disorders, infections, or infestations, really nothing. So the safety profile, again, in this study is out through 13 months and beyond. So some patients, about 30 or more patients, have already crossed and exited the 2-year study, and we continue to see a very good safety profile in all of our studies with the Valeda Light system. So in summary, we did meet the predetermined primary efficacy endpoint with a significant difference between PBM and sham at month 13. Very robust shift in terms of improvement in BCVA, with over 55% showing about a 5-letter gain with a mean of around 9 letters. 26% showed over a 10-letter gain with a mean of about 13 letters. And really, nothing in terms of contrast sensitivity or low-level BCVA. The patients had fairly good vision. We are seeing some consistent effects and reduction in central drusen deposition throughout the course of the study, and an excellent safety profile. So with that, I'm going to stop and allow some questions to be discussed from the Q&A.
Perfect. Thank you, Clark. Let's just go there. The first question is, how many patients have been treated in all the studies done on Valeda?
That's a great question. So we've treated over about 200 patients, depending on Lightsite 1, 2, or 3. We had 2 studies prior to the Valeda that were part of the clinical evaluation report for the CE mark. So we've run now 7 studies, 6 have been in dry AMD patients. And in Europe, we've treated a little over 4,000 patients over the last 3 years, collected in certain centers 200 to 300 patients. So we have a significant database that we're continuing to grow for dry AMD.
Excellent. Thank you, Clark. The next question is to do with the minimum time gap required between the two treatment sessions. And I think this one we can probably go 2 ways, Clark, and should probably do both. One is between individual sessions, and then in between the complete cycle. I think they both merit discussion.
So at least within the sessions, we try to create a fairly flexible 9 sessions over 3 to 4 weeks. In our US trials, over 3 to 5. But typically we say you don't need to treat every day. 3 times a week has been indicated is ideal. If you miss one, come in the 4th week. The idea is we're stimulating the retinal tissue. That creates an upregulation in not only cytochrome C oxidase, but in the electron transport pathway. And PBM has been shown to upregulate probably over 100, 150 different proteins and enzymes. So we're kind of resetting the metabolic activity. And to do that, you get repeat treatments in various therapeutic areas, typically 3 to 4 weeks, and then you get sustained benefits. On the sustained benefits, it can vary between acute or chronic disease. In chronic disease like AMD, we did our first study at 6 months intervals. And in Europe, we typically say between 4 to 6 months, have the patients come in. If they're starting to remiss, schedule another round of treatment. We saw at 6 months with patients that were highly prone to AREDS category 4, over 50% late stage patients, that some of them, about 13 to 20%, were remissing by 6 months. And so hence we moved the studies into 4 months in both Europe and US. But we also did something else. We took out those late stage patients with 2100 or worse vision, because we saw that central GA correlated with response. If the tissue's gone, we really can't fix that. They didn't respond or do as well. So what we've subsequently seen in the electrolyte study is some of these early patients still have improved vision 6 months out. So I think it does depend on where you're at in the course of the disease, and that will be evolved, I think, just like any other drug therapy that comes on. You understand that depending on where the disease is, you may treat differently. Ben, I don't know, you want to add anything to what your thoughts are from your experiences in the trial?
Sorry, no. I was just looking down the next question. How can patients join the study? I think they can't join the study at the moment, can they?
So we do have our CE mark. So we have a registry study that is getting ready to be teed up. We have centers that, like Ben, that want to participate in the registry study, and it allows those patients to also, that were in the sham, to come over and get treatment. So I would reach out either to Ben or some of the other investigators that have devices that'll offer the treatment. Commercially can be located on our doctor locator on our website.
Yeah, and then the next, oh, sorry, go on.
Yeah, this is probably for both of you. Is there a role in wet AMD for photobiomodulation?
Well, can I take this one? I mean, I think that's a really interesting question. And what we know about wet AMD is that people, we're quite good at treating it in the short term, but we know that in 5 to 7 years, people lose vision, and the mechanism they're losing vision from is geographic atrophy over scar tissue. So there may well be, obviously we don't know yet, we have to be a bit wary that the other treatments, the complement inhibitor type treatments that help with preventing geographic atrophy or limiting geographic atrophy do seem to encourage wet AMD, and that there is this link between sort of hypothesized link between choroidal neovascular membranes under the retina, giving the retina more oxygen. That might be a good thing if it's controlled, and if it gets out of control, it causes scarring and so on. And so there might be a sort of a balance where you have more wet and less dry, or the opposite. So yeah, there might be a role, but it would be great if I would just persuade LumiThera to do a study on wet AMD patients with photobiomodulation and see if it. But you'd need a sort of a 5 to 7 year study. So I'm not sure we're going to know the answer to that for quite a while. But certainly I've treated people with wet and dry AMD privately.
Yeah, I would just add to that it's an excellent question. Strategically, when we started, we felt that the patients with dry really had limited options besides AREDS vitamins and lifestyle choices. I'm a pharmacologist by training. I think the anti-VEGF drugs are excellent drugs, very revolutionary for ophthalmology. But as Ben pointed out, the underlying disease continues to march forward. So we did put a wavelength in there that does reduce VEGF expression in retinal epithelial cells to 590 and can improve phagocytosis, with the concept that it might be used either as a, in addition to Eylea or Lucentis or the anti-VEGF, it may be used as another potential to, once you've controlled the neovascularization, haven't got completely the vision recovery that you wanted, maybe there would be some benefit there. Obviously, there's patients that they're resistant, and there are other medications coming forward that are going to address separately GA growth and that. The nice thing about this, it's a local treatment. It's not adding a 7th or 8th drug to an elderly patient. So I think there are opportunities. We have to do the clinical trials, as Ben pointed out. I don't think it's a standalone, but I think it could be used to maybe extend, or maybe to use after you've controlled wet. So there, I think, is a lot of research here that could be done, and we're excited about expanding this as in other areas beyond just AMD. So
it's probably just worth saying that if you've got a patient who doesn't like having injections and says, "Is there anything else?" I don't think this is not something else for that. I wouldn't
yes,
that you could offer that, as this isn't going to cure wet AMD.
No, I would agree wholeheartedly. Our focus has been on dry. We've had a few doctors treat a few patients, but there is not enough data to support that. And I think that the anti-VEGF drugs are revolutionary. They were very powerful. So that's the first line of treatment that needs to be approached for wet.
Thank you. A little shifting gears, what is the data on multifocal ERG or microperimetry in the eyes treated versus the sham? Do we have any data?
We did a small study that's been written up for publication with Diopsis called the Electrolyte Study. And the idea was to look for other biomarkers. We use imaging to identify where the patient is at, but that is still static, and we'd like to have a quantitative, measure of functional vision. And the ERG study allowed us to do a baseline ERG and then measure each week before their round of 3 days of treatment. And what we saw is over the course of the 3 weeks, we got an increase in retinal ganglion output. It was a significant, about a 15% increase in multiluminance area under the curve, improvements in fixed luminance, improvements in negative photonic response as well. And so what we saw was about half the patients actually maxed out around 2 weeks. So it may be able to use that as a quantitative marker to optimize the treatment. And then we followed the patients, and these were the same intermediate as in these 2 studies. And out to 6 months, they still had about a 14-letter gain and improvement in contrast sensitivity. So we do feel that it could be used to also monitor when you need to retreat the patient. So I wholeheartedly believe that imaging and other biomarkers can be used around therapies to monitor and make the best approach at treating this disease.
What about microperimetry, Clark? Have you seen any data on that?
Yeah, in Europe, actually, there's several centers in our Lightsite I. We use microperimetry, and in patients, we've seen, I think, consistently improvements in fixation stability in some of those patients that have fixation stability issues. You can see improvements in visual field. I like microperimetry as another quantitative marker, and I think we didn't use in the bigger studies. Not every center is good at it, but I believe it's a good output marker as well.
Ben,
do you have any experience with microperimetry and PBM?
I haven't used it. It's quite time intensive, and there's a bit of a learning curve getting used to it. So no, we haven't used it yet. We're looking at it for another study actually. But
Okay.
Yeah, I would agree, Ben. That's one of the reasons it's not in our studies. And then two, the later stage patients can have some fixation stability issues, so it's complicated to get a reading on those patients, and can be very, lengthy for the patient. So with everything that we're doing, we've kind of shied away from that. But we do see centers in Europe and in Canada that have used microperimetry and shown benefits. So it's if you have it in your office and use it, it's something that you can see some benefits with.
All right, thank you. Question is, there was only one non-Caucasian in the study shown. Was there any reason for this?
No, there really wasn't. I mean, our centers across the United States were fairly geographically diverse, from rural centers and outside of DC to New York, Florida, North Carolina, Southern Texas, California, Stanford. We do know that the patient population typically tends to be more female, a little bit more Caucasian in dry AMD. Unfortunately, some of the maybe bigger university centers, they did get impacted by COVID more than some of the private ones. So the centers in New York and California didn't get as many as we would have liked going in because of COVID and the university. So that may have had some influence on the overall distribution of patient demographics.
Ben, what was your experience with Lightsite II?
yeah, well, I mean, I just live in an area that's predominantly Caucasian. If you see somebody that's Afro-Caribbean, Asian, whatever, they're probably a doctor or a dentist working at the hospital. I don't know why. That's just the population that we serve. So I have about 2,500 patients treated for wet AMD, and I don't think a single one of them is, not Caucasian. So there just aren't. I couldn't possibly have recruited any non-Caucasians, even if I've particularly been trying to. Which so it's just. That's the population I serve. And if you did the same study in London, you'd probably have a different outcome, or Bradford or somewhere, but not in Great Yarmouth.
Okay, thank you.
I guess it's an interesting question whether the results would be different in a population with higher pigmented, melanin absorption in the retina in darker skinned people. I don't know.
It's interesting. We do have, besides our CE mark, we are approved in several countries in South America. We seem to see benefits there in the investigators that are using it. In terms of the absorption characteristics of the wavelengths, that is a question that's been asked before. Typically, melon will absorb, but it isn't the peak absorbance for either near infrared 590 or 660. So when you look at the absorption peaks and spectrums, those longer wavelengths are kind of free from some of those other contributing factors. Color of the pupil, again, we do a 30 millimeter beam, so we are, it's a bundle of light. Obviously, during the open eye, it's going through the pupil, but even in the 660, we have the patient close their eyes and we can see it go through the skin on the inner eyelid and can get through the sclera. we do know that these wavelengths can penetrate, the skin into muscle and is used in skeletal muscles. So my comment is that there's probably some absorption, but not enough to make a big impact on the overall fluence getting to the retinal tissue.
Okay, thank you. Another question is around the 590 nanometer wavelength. What is the rationale for this wavelength, and what is that we claim that we can suppress VEGF secretion? Any preclinical or clinical data?
Yeah, it was work published by Dr. McDaniel in retinal epithelial cells looking at a variety of wavelengths and their effect on VEGF and a couple other outcome measures. There's been also a group in, I think, around Denver area that's published on some of the 590 in terms of its ability to work efficiently in ischemic conditions and also improve phagocytosis. So there's a smaller body. Most of the technology and research uses red because it's easy to see and it's clearly the most favorite for research. Near infrared is also well utilized, particularly in the CNS where we were doing work earlier in my career because near infrared has the deepest penetration. But there is body of literature for all three, including the 590. That was what we were using to target those different wavelengths.
All right, thank you. Another question, are non-medical personnel allowed to deliver the treatment? I think probably we can handle this in two parts as well, Clark. One is obviously personnel within an eye doctor's clinic, and also possibly are we maybe in other non-medical people having the device and treating patients?
Well, maybe Ben, do you want to talk about how you
well, yeah, we
study?
certainly have non-medical personnel. So Emma Stimpson, who I think is actually on the call, the webinar, does pretty much all my treatments for me. So and runs a very efficient service and did the research trial for us as well. So yeah, no, you don't have to be medically qualified to deliver it. You might want to consider what your insurance status is if it turns out that there is some unexpected side effect down the line. So the insurance for any sort of novel treatment, you just might want to check that you're covered for that. But the other thing is to say that these patients are by definition at risk of wet AMD as well, and just so some sort of OCT scan every 4 months or so might not be a bad idea, or questionnaire about, have you noticed any distortion, or make sure they're using an Anderson grid. So yeah, so I don't think it really matters who gives the treatment, but I think there is a sort of an issue about these are potentially quite high risk patients for developing other conditions, which, admittedly an optometrist could easily pick up with an OCT scan.
Yeah, I think one of the things here, just to expand on that, this is not a laser. We use a LED that's further homogenized and diffused so that we've tested each wavelength for eye safety, and it meets through all the industry guidelines and testing. However, we only sell to doctors. We do anticipate that this is something that can be used in the office by a non-physician under the supervision of a physician, and it could be something that optometry might be able to treat depending on the country and or the local regulations. We felt that this could be an extension for the doctors so that we preload, the wavelengths, do all the testing so that it is fairly easy to learn to do in terms of training. And I think Ben alluded to that earlier, that, a technician can learn it pretty well. But, our clinical trials and all of our customers are MDs, and we don't anticipate selling this to an individual person at this point.
Thank you. Thank you, Clark. Thank you, Ben. Listen, we're I'm almost at the end of our time. So I want to thank you both for being part of our Peer Perspectives program for photobiomodulation. I also want to have a little bit of a plug. I will be at the RCO meeting. Unfortunately, we aren't having a stand there, but I will be there Tuesday, Wednesday, and so if anyone wants to meet and go over some of this information you're going to there, I will be there, and you can reach me at drmorrison@lumithera.com. That's drmorrison@lumithera.com. And if you have any other questions outside of that, you can reach Attila Kaplansi at the email listed below. I just, again, want to thank our presenters and thank each one of you for being on this evening. And I wish you well, and we hope to see you live at a conference near you at some point. Have a great evening.
Ben, thank you. It's been, as always, it's fun getting on and talking with you about our clinical trials, and enjoy RCO coming up next week.
Well, thank you. Thank you for having me. Good night.